Hello, everyone, and welcome to the first town hall in our post-ASCO series. Thank you so much for joining us today as we discuss implications of the data recently shared at ASCO on the RCC treatment paradigm. We are very happy to be joined today by our panel of experts, Dr. Daniel Geinesman of Fox Chase Cancer Center, Dr. Brian Shuck of Ronald Reagan UCLA Medical Center, and Dr. Tian Zhang of Duke Cancer Center. Our panelists will walk us through key data across practice settings, starting with the adjuvant setting, followed by the frontline, then second-line plus settings in RCC. Please feel free to submit questions using the Q&A chat function throughout the session as they come to mind. At the end of the session, the panelists will respond to questions from the audience. On the next slide, we have a slightly more detailed summary of the agenda, and you can see it will be chock full of interesting information across treatment paradigm for RCC. With that, I'll hand things over to Dr. Shuck to provide a summary of the Keynote 564 data.
Great, thanks, Jamie. It's a pleasure to be here with you guys and discuss this really exciting abstract that was presented. We've had a lot of hope for this space, and we'll just kind of dig in and have a discussion where it fits in our current landscape. Okay, so this was a large randomized phase 3 trial of patients who had resected clear cell kidney cancer, and they had to be within 12 weeks of surgery. They got repeat imaging to confirm with central review they did not have any recurrence at the early time. Eligibility was they needed to be very high risk, meaning T2 grade 4, means 7 centimeter or bigger tumor, T3 any grade, or any T4 or node positive or the very high risk group. But they also allowed patients who were resected to NED within 1 year. These are not patients who 20 years later had a recurrence. These are ones that are destined for future recurrences. And again, as expected, typical cohort, well-balanced, good performance status. This was largely done in Europe and other parts of the world. And the way they did the PD-L1 staining, there was a high positivity with that composite percentage score. And then, as expected, a small percentage of sarcomatoid. Next. Okay, next slide. Okay, so basically the data, the primary endpoint of this trial was looking at disease-free survival, which, recurrence, death from cancer, and as expected there, this high-risk population, the results have come back with only a median of about 2 years of follow-up. So at that 2 years of follow-up, the curves have already started to split. And you see at the 12 and 24 months, there seems to be nice separation. Again, median follow-up is still very early, but the hazard ratio is significant, a hazard ratio of 0.68, which is expected with an active agent like this. That and across most of the subgroups, there was slight favoring pembrolizumab, again, subgroup analyses, but it'd be interesting to look at which groups do best. And you see at that 24-month mark, 77 versus 68. Next slide. Now, it is very early. The overall survival, it is starting to separate a little bit. And again, 96 versus 63%. These are looking at any deaths. And we're looking at a low number of events right now. Pembrolizumab 3.6 or placebo at 6.6. So that does look like promising data. The hazard ratio is 0.54, but the studies have a pre-specified number of events required and a necessary p-value for something to be considered significant. And at this time, even though it's very encouraging, there's not that many events, there may be an early signal. So we'll see. Next slide. And then looking at safety results. So we do know from other studies with monotherapy pembrolizumab, including the Keynote 427, I think the A cohort, single agent pembro is pretty well tolerated. As you see, the number of AEs are high, but expect in both groups people who are recovering for surgery occasionally have some complications. But the grade 3 to 5 complications were quite low, 32 and 17% pembro and placebo. And then just looking at treatment-related AEs, obviously favoring more Pembro, but the grade 3 to 5 toxicity was only about 18.9% treatment-related AEs. So again, pretty well tolerated and no treatment-related deaths, but some treatment-related discontinuations of therapy. Next slide. And here, just looking at the side effect profile, looking at what is seen. So fatigue, pruritus, hypothyroid, more common. Again, with Pembro, as expected, no surprises. Most of these were grade 1 or grade 2, and low number of grade 3 toxicities. Next slide. So I think I'm on a point right now for timing, but this obviously is a very exciting first look at the trial. But where does it fit into our current landscape and prior trials? A nice slide to kind of see where we are. But there are a whole host of trials. The next slide that have taken place in the adjuvant setting. Do we have that slide? But basically, looking at the on the left, all the targeted trials, which we're looking at the TKI agents, sorafenib, Sutent, pazopanib, everolimus, axitinib. The only one that we can talk about later is STRAC, which did have a disease-free survival, a positive signal. And here's where pembrolizumab fits in here with Keynote. It's the first to report. And nivolumab, the PROSPER study, just closed as of June 2nd to accrual. Emotion, about a year and a half ago, it did also close to accrual. The Checkmate trial added another couple hundred patients. It now is about 1,500 patients. It was 800, but they added a nivolumab monotherapy arm about 6 months ago. And then this Rampart study looking at Durva or Durva-Tremi versus placebo. Okay, so we'll open it up for some discussion.
Awesome. Thank you so much, Dr. Shug, for sharing that summary. And I think a really big question on all of our minds are, what are the implications of this data for practice? We'd be interested to hear from your perspective as a urologist and the other panelists from their perspective as medical oncologists.
Yeah, I mean, I would tell you that we see patients every day we go to surgery. I mean, like my patient on Wednesday, I know he's going to recur. He had a 20-centimeter tumor with an IVC thrombus. I expect he's going to recur. He's going to recur early, and we've just not had effective agents that we think are going to be offering durable remissions. And again, the Sutent data, there was a little signal. It didn't improve overall survival, but the mechanism there is not one which you would think would lead to remission of disease. We do know that Pembro monotherapy, at least in that Keynote 427, there are some complete responses, and you think with less disease burden, maybe you would do better. So I think we're all very encouraged. I do know that, we do want to see further maturation of the data.
Brian, I take it as a really patient-by-patient approach, right? These trials are written at population levels of disease-free survival benefit across cohorts, but it's really going to be an individualized patient discussion about whether pembrolizumab after surgery makes sense for that patient in front of us. So your patient who's 20-centimeter tumor IVC thrombus is high risk for disease recurrence. We saw the cohort of metastatic disease who underwent metastasectomy, small numbers, but I would say those patients are quite at risk for more disease recurrence as well. And so, it really does depend on the patient sitting in front of us. And if it's, a stage 2 tumor that, was well encapsulated, was well within the kidney and did not involve any lymph node at the time of surgery, then it becomes more of a risk-benefit analysis of, how much toxicity might pembrolizumab have, and does it really make sense for that patient? So for me, I think it's going to be more individualized decision-making and thinking about risk for recurrence. Dan, what do you think?
Yeah, I completely agree. I think this has to be a shared decision-making process. And I guess the few things I think about in this is, if you think back to the TKI data, there was a conglomerate of studies that really helped to solidify the notion, like you said, Brian, that this doesn't make sense. It wasn't just one. And as you pointed out, there's a number of other trials that have either completed or ongoing. And I would be looking forward to seeing those results. I'd like to see consistent results among the immunotherapy trials. That's number one. Number two, I still think that overall survival is critical. And I know that wasn't the primary endpoint, and I know that there was agreement, a priori, that this would be the primary endpoint, which was met. But if you think about the student data, there was a 1.2-year disease-free survival benefit for that trial, and yet no overall survival benefit at the end. And you're right, the mechanism of action is totally different. But when you're thinking about giving potentially toxic therapy, which this is, and although in the metastatic setting, we accept that toxicity much easier, in the adjuvant setting, we have to be careful, because some of these folks will be cured, will never recur. And this could really change quality of life if you get some sort of a serious immune-related AE. And it takes just a few to really make a difference in sour urtate. So I think we have to be careful, certainly in those patients like the ones that already have had metastatic disease, had a metastasectomy, as you said, patients with large tumors, lymph node positive disease certainly may make sense. But really, I think joint decision making will be key.
Perfect. Yeah, I did have one slide just showing, the data with S-TRAC, and the hazard ratio was 0.76. So this is a little bit, more striking, 0.68. But that, the hazard ratio with OS clearly, just to see, 1.01 was not significant, and that was, now data is very old now, and we're just very early number of events. So hopefully we'll see. And I think it's a big question what people will be treated with for recurrence. The trial was not done in the U.S., mostly 25%. Are they not getting access to immunotherapy in another part of the world where, maybe the OS advantage is significant, but that's due to imbalance in their first-line therapy, which does concern me with that data.
Yeah, exactly. And I mean, that is a whole separate discussion, which is what happens and what do we do if we give somebody adjuvant pembrolizumab and they unfortunately then recur? What do you treat them with? I don't know if Tiana has any thoughts on that and how we think about it, but it really would change the paradigm completely.
Right. Dan, that is actually mirroring two of the questions that we have here in the chat. So it's a very timely question. I do think it depends on the timing, right, of recurrence. So if you've given that patient a year of pembrolizumab per 564 and they're disease-free for a year afterward, then I think immunotherapy re-challenge might be quite beneficial. And any of our IO-TKI combinations in the frontline setting, even trials, pedigree is written to allow for adjuvant immunotherapies. And so, I think it really depends on the timing and whether we think that person's already resistant to immune checkpoint inhibitors. And if it's within 3 to 6 month window, I think taking a alternative approach and using more VEGF inhibition might very well be warranted if they truly are resistant to checkpoint inhibition.
Yeah.
Awesome. Thank you so much to our panelists for your thoughts so far, and we can certainly circle back to this topic during the Q&A at the end and answer more audience questions, as it is quite, I think, an exciting and groundbreaking study. But for now, let's move on to the frontline setting. And Dr. Zheng, I'll turn it over to you to walk us through a couple of abstracts here.
Great. And thanks so much, everybody, for joining. We just wanted to highlight a couple of follow-ups from first-line phase 3 studies. The first one up here is Keynote 426 with a 42-month follow-up presented by Dr. Rini and colleagues. Next slide, please. The overall survival and the intention to treat population here for patients treated with pembrolizumab and axitinib versus sunitinib was updated. You see here the hazard ratio is pretty much maintained at 0.73. The curves stay nicely separated. And the 3-year landmark is 63% for pembro and axi versus 54% for sunitinib. Next slide. In the progression-free survival update, we saw that the curve still stays separated, but at the 36-month follow-up, we're still not quite seeing a tail on this curve. 29% progression-free for patients treated with pembrolizumab and axitinib, 15% for those treated with sunitinib, and the hazard ratio here was 0.68. Next slide, please. I thought the objective responses were very interesting, particularly the complete response rates. We know that some of the delayed responses from immunotherapy-based regimens can occur later on. And so here we saw the complete response rate increase to 10% and overall objective responses at 60%, which is pretty comparable to the 426 updates from before. Next slide, please. Looking across IMDC risk groups, of course, IMDC risk groups are basically the only clinical criteria we currently have to choose treatment options. Overall survival, we know to be driven by patients in the intermediate and poor risk group, and we see that hold up here as well. You'll see progression-free survival benefit are both in favorable risk and intermediate poor risk disease, and the complete responders a little bit more in pembro and axi combinations. Next slide. And then moving on to CLEAR. So CLEAR was a study of lenvatinib and pembrolizumab versus lenvatinib and everolimus versus sunitinib. Here we're looking specifically at the lenvatinib and pembrolizumab compared to sunitinib analysis for subgroup analysis in the IMDC criteria. Next slide, please. So here you see the Kaplan-Meier curves for intermediate and poor risk disease at the top with a hazard ratio of 0.36 for progression-free survival. So certainly a lot more benefit in the intermediate and poor risk group receiving lenvatinib and pembrolizumab than sunitinib. And also in the favorable risk group below, hazard ratio was 0.41. Here the curves are not as separated as they are in the intermediate and poor risk disease. Suggesting that some patients in the favorable risk category are still angiogenically driven, and sunitinib can be helpful. But overall, lenvatinib and pembrolizumab have improved progression-free survival across these IMDC subgroups. Next slide, please. Overall survival for these IMDC risk subgroups in the intermediate and poor risk disease up on top, you see the hazard ratio of 0.58. Here the medians have not been reached yet as of the last follow-up. And in the favorable risk disease, very similar to what we see in other phase 3 studies in the first-line setting, we are not seeing separation of these curves, mostly in these early 2 years or so. Median follow-up, these favorable risk patients tend to do very well, and we may see, still have yet to see the curves separate later on. So more follow-up is needed to see overall survival events in the favorable risk category. Next slide, please. Here's a summary of the tumor responses across intermediate and poor risk and favorable risk disease. Of note, I think probably the highest numbers of complete responders that we've seen so far, 14% of patients in the intermediate poor risk category with complete responses to lenvatinib and pembrolizumab, almost 21% for favorable risk disease. And one thing that I point out to our patients in clinic is patients who present with de novo metastatic disease, so with target kidney lesions here on the far right-hand side, you see very few of those patients achieve a complete response. So I tell patients that when we're starting treatment and they still have their kidney intact, their primary kidney tumor intact, that complete responses are very rare to achieve in those settings. Partial responses certainly can happen, so a pretty high objective response if we combine the two, but complete responses are very rare for patients with de novo metastatic disease. Next slide, please. Here you see a cross-trial comparison of the currently read out, with the exception of Javelin, but currently read out phase 3 studies in terms of progression-free survival and intention to treat group categories with, and then separated out by IMDC favorable versus intermediate and poor risk disease, as well as overall survival in the second half of the table. Again, then also separated out by intermediate and poor risk versus favorable risk disease. Next slide, please. And I just wanted to highlight the landscape of phase 3 trials. We've now had read out about 6 studies total with immunotherapy-based regimens. These phase 3 trials were all compared against sunitinib. We have now slowly merged out of the sunitinib-controlled phase 3 trials. Pivot-09, I think, probably was the last one that's hedged on either sunitinib or cabozantinib in the control cohort, and it has completed accrual. The first of the triplets, so Cosmic 313 with Ipi, Nivo, cabozantinib, has also completed its accrual. And then Pedigree, our study in the Alliance Cooperative Group that's adapted for 3-month responses after ipilimumab and nivolumab, is actively ongoing. There is another study called PROBE in the SWOG Cooperative Group that's immunotherapy-based combinations with or without cytoreductive nephrectomy, so also adapted for responses. And then finally, another triplet treatment in the first-line setting, the Merck study that's with belzutifan, lenvatinib, and pembrolizumab, building on what we've learned from the CLEAR study. So these 3 at the bottom are actively enrolling. So certainly still requires a lot and of participation from our patients, and we can build on what we've learned and these immunotherapy regimens that have become standard for our patients in the last 3 years or so. And with that, I think we'll, next slide, take more of a discussion or go to the Q-twist. We'll go to Q-twist. All right, Dan, all yours.
Yeah, sure. So, and I think when we talk, we can sort of put this all together, but you just nicely went over sort of the efficacy data, but you know, we're seeing a lot of quality of life data come with these trials. They're all incorporated quality of life questions in these big trials. And we saw a few abstracts, a few posters about that at ASCO. And so let's go to the next slide. What do we have there? Right, so this is Q-twist, and I think most of us are not familiar with this. We're usually seeing more sort of quality of life questionnaires like the FACT or the EORTC questionnaire. This method actually has been developed many years ago, 30 years ago, but the idea is to look at sort of 3 states. You look at toxicity, so a period of time that a patient has actually significant adverse events, grade 3 or 4. A period without symptoms or toxicity, so that's sort of your best state, your good health, that's the light blue, okay? And then you have the relapse, okay, the period of time after disease progression. And what you do is you assign different utility scores to each of the states, okay? Obviously, the best utility score, the highest, would be to the twist state, the light blue one. And you can vary this utility state, and there's not one kind of quite right answer, but the idea is to see what's the relative gain of the good state, the light blue state. And what you see is there were actually 2 separate posters, one for Checkmate 214, so Ipi-Nivo versus Sutin on the bottom, and then one for Checkmate 9ER, Cabo-Nivo, using this approach to take a look at the benefit to the patient. And if you look, for example, at the Checkmate 9ER on the right side, you will see the absolute Q-twist gain. And so if you look starting really at month 3, it starts to rise, and by month 33, it's at 4 months. But then you also look at the relative gain, and that's at about 17%. And there are benchmarks that have been set as to what is actually clinically meaningful. What is a clinically meaningful relative gain? And it starts at about 10%, and above 15%, it is sort of a definitive, very clinically relevant gain. And you can see that actually both for Checkmate 9ER at 16.9, and then if you look down below for Checkmate 214 at about 21%, both meet that threshold. And really sort of the idea here is that this supplements the efficacy data showing that compared to sunitinib, right, which both of these trials were compared to, the quality of life, the gain to the patient being in a good state, the state that we want to live in, is quite significant. So that was there, and there were certainly a few other quality of life analysis, sort of more traditional ones that were done for CLEAR. Next slide. Okay, we move to the next slide. There we go. Yeah, so this is the CLEAR quality of life analysis, and let's move on to the next slide. Tian, were you going to speak quickly to that, or should we just simply discuss this together as a group?
Yeah, we were, I think, going to discuss this together as a group, but most of the quality of life metrics tended to favor patients treated with lenvatinib and pembrolizumab. Sometimes I have trouble in quality of life metrics to know what's because of disease improvement and what's coming from the treatment. But as an overall, it seems that for these metrics, most of these are favoring the combination based treatments.
Yeah, and I think whether it's on this slide or I think the next slide, sort of different questionnaires and different ways to assess quality of life. I think it's difficult because I think it's fair to say that as oncologists, we are not as savvy as sort of statisticians and epidemiologists to understand this. It's hard to say where the thresholds are and what they mean clinically. And I do find it difficult to discuss this sort of in real time with a patient and really incorporate this, other than to say that what you want to make sure is that the sort of treatment that improves survival, improves response rate or PFS is also not worse in terms of quality of life. You want to make sure that at least that's met. And I think we can say that clearly for example, lenvatinib pembrolizumab, or frankly for cabozantinib nivolumab, that it's not worse. And then I think you fall back on the efficacy endpoints. I don't know if Brian has other sort of thoughts about quality of life from a surgical perspective.
I mean, for here it's hard. Is it the drug less toxicity, or the patient is feeling better because they have better disease control? It's always hard to figure that out. Right.
Yeah. Why don't we go to the next slide? Let's move on here for just a second. Oh, let's stop there. Yeah. So I don't know, Tian, do you have any other thoughts before we move on to Checkmate 920 for quality of life?
Just looking at the Q&A, there's a question about how we incorporate quality of life into our treatment decisions. In general, I tend to tell patients that we try to give them a treatment that will extend their life, but also preserve quality of life. And so the metrics are good. Some of I think the questionnaires differ from study to study, and they're not standardized. But in general, we do try to pick treatments that have, are better tolerated, have better patients who have better quality of life while on treatment, is how I would approach that.
Yeah, and I think I would say if you had two treatments that had absolutely similar outcomes in terms of efficacy, and then there was a really significant distinctions in terms of quality of life metrics, I think that would be very helpful and in making a treatment decisions. It seems that it typically is not the case. It typically is that they kind of go hand in hand, and certainly in RCC, that's been the case. I think that every successive treatment that's made an impact and improvement, for example, over sunitinib, has had at least as good or better quality of life. I think you can have some discussions. For example, pembrolizumab seem to be sort of much more similar to sunitinib than, for example, cabozantinib with nivolumab initially. But those are somewhat tough to distinguish. When were the questions asked? What exactly, as you point out, the questionnaires were? What was the patient population like? So it is challenging, I would say, to incorporate that sort of robustly into clinical practice.
It does sound like this question around quality of life and how it should factor into the treatment decisions is very top of mind right now. We're getting a bit more data across trials on that topic. Maybe we can circle back to that in our Q&A later on. For now, Dr. Genisman, I'll turn it back over to you to bring us through a couple more subgroup analyses.
Yeah, so these were posters so that looked at specific kind of maybe a little bit more niche questions, but actually some questions that come up quite frequently in practice. And this is from Checkmate 920, which was really kind of a phase 3b/4 trial looking at ipilimumab and nivolumab in populations that normally are not included in clinical trials, and looking more at sort of, I would say, real world outcomes in them, although through a clinical trial lens. So if we can go back to next slide. Yeah, so this was looking at the safety and efficacy of nivolumab and ipilimumab in patients with brain metastases. And as someone's so familiar with, a lot of times these patients are excluded from many of our frontline clinical trials. They're not allowed to go on. And so it's really of great interest to see how they do and how they fare on this therapy. And although the sample size was not large, it was approximately 30 patients. You can see here that the progression-free survival was about 9 months, and there is a tail to that progression-free survival curve around 17%, although the number at risk patients there is very low. But interesting, if you look at the overall survival there, if you look at, for example, 24 months overall survival, we're at around 60%. Remember, these are patients with brain metastases. Almost all of them had some sort of local therapy to the brain metastases before going on to this trial. If you look at the response rate, you can see partial response 32%, quite in line with what you would expect with ipi/nivo, right around 39-40% there. And then if you look at actually the type of progressions that occurred, patients with intracranial progression, about a quarter, but that means that 75%, 3/4, actually did not progress intracranially. And if we actually looked at the toxicity, there really were no new signals here. And I think the takeaway message, at least for me, is that if you're a patient, if you have patients with brain metastasis, this is a very reasonable regimen. Does not seem to be much worse than in those without, and you can safely, most importantly, safely deliver this patient with brain metastases. And we think that a lot of times that vascular endothelial growth factor receptor TKIs do not penetrate the blood-brain barrier. They're not that great. Immunotherapy may be better, and so I think we do sort of seem to favor immunotherapy approaches in patients who have brain metastases if they can receive it, or at least give them a shot at that. And this gives nice supporting evidence toward that. Next slide. And then, sort of shifting gears to non-clear cell RCC. So remember, when all the discussions we've had so far has been about clear cell kidney cancer, and that represents 75%, 80% of all kidney cancer. But about 20% is non-clear cell, and it includes lots of different varieties. There's about 13 to 15 of them, actually, if you look at the World Health Organization classification. But by far the most common is something called papillary, which itself can be divided into papillary type 1 and papillary type 2. And there's been a lot less work done for this for many years. Really, the way we would treat non-clear cell RCC would really be the same as clear cell. We would simply extrapolate the data, extrapolate the drugs, and just try them. And what we would see time and time again is that the outcomes would be worse, that they would not be as efficacious as they were for clear cell kidney cancer. And that's in large part because of the biology and the difference in, for example, VHL and VEGF dependence. So this was a trial of nivolumab and cabozantinib in patients with non-clear cell RCC. So if we go to next slide. Right, so this was a single center study from Memorial Sloan Kettering. You can see that there were two cohorts, a chromophobe cohort and then a non-chromophobe cohort. I'll call it mostly papillary, but a little bit unclassified, and a few with translocation associated non-clear cell RCC. And they received cabozantinib 40 milligrams and nivolumab. And you can see here that the median PFS was 12.5 months. And just to put it into context, single agent sunitinib for non-clear cell RCC group, the median PFS is somewhere around 4 to 5, maybe 6 months. And then recently at ASCO and then published in Lancet, really I would say the standard of care now for papillary RCC trial was presented PapMed, which evaluated multiple agents, but really cabozantinib was the big winner. And there the PFS was around 9 months, and the response rate was around 25%. So if you look and say, okay, if that's the standard of care, here we have a median PFS of 12.5 months, a median OS of 28 months, and you have an objective response rate in that first cohort of almost 50%, 47.5%. So impressive, I would say, results in a small group. And there are other studies of TKIO combinations ongoing. So, for example, lenvatinib pembrolizumab is about a 150-patient trial that is about to launch worldwide, looking at non-clear cell patients. Next slide. And then, so here's another approach. This was a trial of durvalumab, an anti-PD-L1 agent, with savolitinib, which is a MET inhibitor. And the story here is that savolitinib was evaluated in sort of a phase 1, phase 2 trial of about 100 patients and showed a reasonable response rate around 20%. It then went on actually to be studied in a phase 3 trial against sunitinib, but that trial had to be stopped prematurely with very few patients enrolled. There was only about 30 in each group. And though savolitinib numerically was superior to sunitinib, it did not meet the statistical pre-specified threshold. And so then the next step was to sort of say, okay, well, can we evaluate an immunotherapy plus savolitinib approach? And this data for the entire group was presented previously, but what the authors did here is they actually tried to pull out specifically MET-driven patients, and they had a specific definition of what that is. And to be MET-driven was not just having sort of IHC high staining. It was, you have to have chromosome 7 gain, you had to get MET amplification, you can have hepatocyte growth factor amplification, and if you look at these patients, so if you look at the progression-free survival curve in the upper left, you can see everybody at first. But then on the right, you can see they're separated by MET-driven and not MET-driven. And MET-driven is in blue, and you can see a big difference. So 10.5 months, for example, versus 4.9 months, a doubling in progression-free survival. And if you look down below at overall survival, median overall survival, 27.4 months versus 14 months. So again, basically a doubling of that. And then on the right, if you look at the response rate for MET-driven patients, 57%. And the waterfall plot kind of shows that in the 13 MET-driven patients, you can see almost all of them had some tumor reduction. So this sort of, I think, builds on the story that if you rationally select, if you have some really good biomarkers and you're able to pick out the folks using those biomarkers and you have the right drug, you can actually really make substantial headways. And then the other thing that it says, and I think what the previous trial also said, is that in non-clear cell RCC, there is some activity to VEGF TKIs, right? There is some activity maybe to MET inhibitors, but there's also some activity to single agent checkpoint inhibitors. And there's been multiple retrospective study and a prospective study of pembrolizumab. And so if you combine them together, it's not clear if it's synergistic, but it certainly seems like there may be an additive effect there. And so the combinations really do make sense. Next slide. Okay, I think we have panel discussion time here.
Yeah, thank you so much for that summary. Just to stay on time, I'll ask just one question here, and of course, members of the audience are free to submit their questions as well. I guess just kind of a broad question, would you consider any of the results we've discussed really practice changing, either with regards to the broader population or any of the subgroups like patients with brain mets or non-clear cell patients?
And you're talking about from the beginning of our talk, right? Including the adjuvant pembrolizumab data?
I would say excluding the adjuvant segment.
Excluding
we've already discussed a little bit how that
sure.
likely will be practice changing, but for the frontline setting.
Right. I don't think so. I don't think anything that we have discussed after adjuvant, in my opinion, after adjuvant pembrolizumab is truly practice changing. I would say it's practice confirming. So the data that Tian showed with longer follow-up with axitinib and pembrolizumab is really practice confirming. I think the quality of life data is encouraging in that it doesn't show any detriment to the combination therapy. And I think the non-clear cell data is intriguing. It's interesting, but I think the sample sizes are quite small, although in sort of real life outside of clinical trial practice, I would say quite a few people are probably considering using combination of a VEGF TKI and an IO agent together. So just like you saw, for example, Cabo-Nivo or Axi-Pembro and Vatin Pembrolizumab, these things are under clinical trial investigation. But I think outside of that, it's not unreasonable to do so. And I know I certainly have in practice. I don't know what other folks think. I don't know what Tian thinks.
Yeah, Dan, I agree. I think it's helpful to have the data from 920, right, for brain metastases, and to know that we can use ipilimumab, nivolumab in those settings. Certainly, I think treating a symptomatic brain met locally makes a lot of sense, and then proceeding with immunotherapy-based combinations is generally our standard. And so I would agree with you. A lot of this is practice confirming. The papillary data I thought was really interesting, and I'd love to see further trials done in that space. Purely, because we have such little data, and recent PapMet aside, and use of cabozantinib for metastatic disease, I think it really doesn't have the level of data that we have for clear cell kidney cancer. So certainly would love to see more trials done in that space.
And what other trials are you almost excited about in the frontline space?
Oh, I think every day about pedigree, but I think the triplet belzutifan probably has the most exciting data in the refractory setting, and so I'd love that we're bringing it forward in the frontline space, and I'm looking forward to seeing the activity that I'll have for first-line patients. Brian, your thoughts? What are you excited about?
I agree. The HIF2 belzutifan is the most exciting kind of thing to move forward. But the Nivo Cabo, we're seeing a patient with recurrent papillary kidney cancer today, and I'd like to say Cabo should be the standard of care based on S1500, but the data combination, if you have an approved regimen of Nivo Cabo, like why wouldn't you use that in that patient population now? But again, a trial should show its superiority to the monotherapy. Yeah,
I agree with everything that's been said. I think I am interested in sort of Ipi-Nivo Cabo. I think it'll see if we can push the bar higher, get the response rate and really the complete response rate even better than we've been able to do with, let's say, lenvatinib, pembrolizumab. So I think I'm interested as well in that. I will say part of me is a little nervous about bringing all our best drugs all the way up front. So I know, for example, the HIF2 alpha inhibitor is definitely exciting. But when you bring everything you have up front, part of me worries about extra toxicity, and part of me worries about using everything out. But that's a sort of a controversial, I think, topic. But
I think if your CRs become 20% or greater, then it's definitely something to consider. That your ammunition's empty, but you definitely made a big dent.
Yeah, I agree. If you can truly, if the CR rate is the one that you push up and you really get more cures, let's just use that word, or ongoing remissions for a long time, I agree. That certainly would make it worthwhile. Yeah.
Mm-hmm. Then we have an interesting question coming in from the audience. Are there any promising biomarkers to predict responses for checkpoint inhibitors? Obviously, that's been very involved in a lot of the combinations we're talking about in the frontline setting. Any biomarkers that seem promising for that?
The holy grail. We'd love to find, predictive biomarkers that can help us select treatments for the right patients for the right treatments. I love the gene expression profiling that was done in the emotion trials that was just published in December. Love to see those used in prospective studies to select patients for immunotherapy-based combinations. I think if this audience is interested, there are some interesting data coming out about neutrophil eosinophil ratios from Brian Reeney's group. Matt Tucker is the first author from a GU ASCO poster that we showed in February, and then they used a Javelin Renal 101 as a confirmatory validation cohort, and that was presented at ASCO just this last weekend as well. So neutrophil eosinophil ratios can certainly is more quantitative, I would say, than our IMDC criteria, and it can be part of the complete blood count and differential. So it's an easy to access biomarker as well. But certainly would love to see more done in this space so that we can actually select the right patients for the right treatments. Brian, Dan, anything come across your plates?
I mean, I would definitely, what's striking from that paper that Tiana's mentioning from the motion study is there's all these different transcriptomic profiles, but the mutations and like PBRM1, SETD2, VHL, they're all totally, different between, or there's overlap between each group. So you can have a PBRM mutation, you could be in one of like 4 different, groups. So I think it's going to be more transcriptomic than genomic, because due to the subclonal nature, and the landscape is changing so rapidly, you might have an agent that is good picking out who's going to do better with monotherapy Sutent instead of Pembro-Axi, but who's to say that Pembro-Axi is going to be relevant in a 2-3 years? Maybe it's all triplets.
Right. The only thing I would add, maybe to that quickly, is that PDL1 is not a good biomarker, and it's just not enough. And it's a very common question that is asked, when we talk to patients, and the answer is we just don't use that very much to select therapy. And we need other things. I completely agree, but my guess is going to be a lot of work and a lot of time before we have something like that, due to, I think, just the inherent nature of the disease and the heterogeneity of the disease.
Yeah, it sounds like hopefully over the next few years, we'll maybe see some more work on that. And thank you all for offering the perspectives on the current situation there. I think with that, let's move on to the second line plus setting. And we'll kick off the conversation here with a description of the Cantata trial.
Yeah, and I think we can go through this relatively quickly, so we have a little bit of time at the end to just answer any other questions. But this Cantata trial was a randomized global phase 3 trial, about 400 patients, and included patients who've had 1 to 2 prior lines of therapy. And it compared cabozantinib and placebo to cabozantinib plus a drug that was called telaglenastat. And well, here's the answer. Yeah, there was no difference. There's no difference. The rationale was that kidney cancer certainly can rely on a lot of metabolic pathways, and there was preclinical data, and there was a smaller trial in the past using this compound to try. It's a glutaminase inhibitor to try to prevent sort of the use of sugar by cancer cells. They sort of use it slightly differently due to the Warburg effect, and this glutaminase inhibitor, the idea was, would synergize with cabozantinib to decrease fuel to the cancer cells. That was the thought. Unfortunately, as you can see, really no matter how you slice and dice it, there's really no difference in the progression-free survival, which was the primary endpoint. Certainly no difference in overall survival. And the only maybe glimmer of sort of hope there was in folks who just recently, within the last 3 months, came off checkpoint inhibitors. Those folks seem to have a couple-month numerically better PFS, not statistically significant, but numerically higher. And you can see that in the upper right. Sort of begging a question, is there something about that group that somehow sensitizes them to telaglenastat? And certainly if one wanted to and had the resources and some good rationale to study that. But right now, unfortunately, this was a negative trial, and it would have been a completely new mechanism of action if it was positive, but unfortunately it's not, and so we're not gonna see that anytime soon. Let's move on to the next slide. Yep, and I think Tian, you're going to briefly cover that slide.
Yeah, so CONCEPT was a phase 3 trial of vorolanib, everolimus, and the combination of vorolanib with everolimus that was performed mostly in China and presented by Dr. Sheng at ASCO. Next slide. This was in previously treated clear cell kidney cancers, and there were patients were randomized to 3 cohorts. So vorolanib or everolimus on their own, or the combination. And as you see from these progression-free survival curves, the combination in red delayed time to disease progression. Hazard ratio was 0.7. But the combination really didn't improve overall survival, the curve on the bottom. And so I think with this combination, it's moving the field forward in China, where sometimes access to certain VEGF inhibitors are a little bit more limited. But the question is the combination, the toxicities of these, is it worthwhile to delay progression? Or are we really looking to improve overall survival? I would say probably this trial was not powered for overall survival differences, but progression-free survival was their primary endpoint. And so we kind of, it's their equivalent of our lenvatinib and everolimus combination, and it did improve median progression-free survival. Next slide. I think that was the one slide what we had for CONCEPT. So I'm certainly happy to address any questions from these promising studies in the second-line setting.
Yeah, I would definitely encourage the audience to submit any questions they have. I guess something on my mind, we talked a little bit about the concept of IO retreatment back when we were talking about Pembra's adjuvant. What would be the implications of that for patients who do recur? Now thinking about the second-line setting, we're starting to see some IO retreatment investigation here, I think particularly with the CONTACT-03 trial. It's the first pivotal trial looking at that approach. So I'd be curious to hear your thoughts on kind of the potential and the promise of that approach, and if there's any particular patient characteristics you would look for, or just your thoughts on the potential there.
Well, I mean, I can jump in. I mean, so the CONTACT trial randomized folks to cabozantinib versus cabozantinib and atezolizumab who've had prior immunotherapy, asking really the question that you're asking, which is what is the utility? Is there a utility to another sort of PD-1 or PD-L1 inhibition after you've just had that? And that's an open question. I will say that the data for lenvatinib pembrolizumab is out there, where that combination, not in the frontline setting, but in the second and third line setting, was actually quite active. And this were in folks who almost all of them had prior checkpoint inhibition, more active than you would expect with lenvatinib alone. So I think from that, to me, there's certainly a signal that with the right combination, it may make sense to retreat with immunotherapy, even if you've had immunotherapy in the past. How to select folks for that, though, and for whom it'll work or not in biomarkers, I don't think we know.
Yeah, I would definitely agree with that. And, certainly in our patients who are living longer with kidney cancer, it's becoming more of a chronic disease for our patients. And so, we do try multiple combinations in the refractory setting. I do think CONTACT-03 is a great study to help us support that decision-making process of using cabozantinib-based immunotherapy combination, cabo-atezo, in the refractory setting. we don't have, grade 1 evidence to really say, yes, these are active combinations in prior immunotherapy treated patients. But it's certainly a standard, I think, to offer at least the combination treatments, even in patients who have been exposed to immunotherapies. Certainly something that we would offer in the post IO exposed patients. And it really depends on the mechanisms, I think, and how we're going to think about treatment resistance. If a patient is coming off of ipi-nivo and nivo maintenance for a long period of time, then maybe they might benefit from adding a VEGF inhibition on top of their nivolumab monotherapy, or going to a different combination. So it all depends, I think, on the timing and resistance patterns that we're seeing in the patient in front of us.
I had a question maybe for Brian Tian. So to go back all the way to the beginning and those overall survival curves for favorable risk patients, really not separating yet of IO TKI versus TKI alone. Is there a role for single agent TKI in favorable risk patients at this point, or are we fully beyond that?
I do remember on the NCCN panel the past couple of weeks is when is it time to remove Sutent at all, from a first line, and the data for the ipi-nivo and now this, there are some patients who probably benefit from monotherapy and may not need to be exposed, but it looks like another interesting conundrum with the favorable risk patients.
To add to that, I do think there's patients who would benefit, right? These registrational trials are for drug registration and approvals. And so we're seeing differences between populations of patients. For the patient in front of us with favorable risk disease, particularly those with pancreas metastases and oligometastatic disease, I would think about using a single agent, sunitinib, pazopanib, for that patient to try to avoid the immunotherapy toxicities. And we've actually had very good success with single agent TKIs in that setting. Pancreas Mets were published last year by Jim Brugarolas and Brian Rini. And in that small cohort of patients, but I think meaningful, they showed that pancreas Mets are sensitive to VEGF inhibition and not to nivolumab immunotherapeutics. And the signature is certainly angiogenically driven. So for that particular niche population, I will offer a monotherapy VEGF TKI first.
Yeah, I certainly have a few folks still that I do the same and offer single agent TKIs, reserving IO for a second line or combination IO TKI for second line.
Yes, continuing on the topic of the kind of angiogenesis axis, we were talking a little bit before about belzutifan and bringing it into that triplet in the frontline setting, but I'd be curious to hear your thoughts on the other settings in which it's being investigated and where you might imagine fitting it into your treatment paradigm.
I personally am so thrilled for our VHL population. I've about 60 VHL patients, and it has FDA breakthrough status, and hopefully it'll be something to be considered by the FDA strongly. But that's a very a difficult population to treat, and it is something where if we can avoid surgery, prevent some of the morbidity, it'll be a real win for that community.
I completely agree. We also saw some promising efficacy data of belzutifan with combination with cabozantinib, and it seemed still tolerated. A little bit more hypoxia than I would like to see for adverse events, but certainly I think very promising in the refractory setting.
Yeah, I agree. I mean, the nice thing with the VHL is that these patients are able to stay on the drug. It's a much sort of better tolerated drug, right, than the VEGF TKIs, and so you can really go on and think about it using it for a long time, yeah, which is what you sort of would need to do, or maybe doing it intermittently, right, in an intermittent fashion. So
I mean, I do think of it, Dan, just as like the everolimus population and the TSC, where you're
Right.
on and off it, on and off it. It's something which will be interesting to see how it develops. But as Tian mentioned, that hypoxia in the VHL patients, they're very different than the metastatic. So I think they seem to tolerate it a little bit better with lower grade 3 events, and enough where I'm going to be comfortable giving that.
Yeah.
Good.
Yeah.
All right, well, certainly something to look forward to, more data there. And thank you again to our panelists for sharing your thoughts and for summarizing all of this interesting data coming out of ASCO. Thank you to our attendees for joining, and we hope that you'll consider joining more of our town halls. But thanks again to our experts for kicking off our town hall series, and we hope to see many of you again soon.
Thanks very much.
Thank you. Thanks for having us.
You guys, thanks.
Bye.